Okay, so my name is Bret Palmer. I'm a consultant in sexual health, as introduced by Barrett. What I'll be doing is going through an overview of what sexual health is. Now, there's far too many slides here than I can possibly cover, and some of the slides I'll skip over. But for those of you who want to have a quick review and have a little bit more in-depth information, then it will all be there in this slide pack if you want it. We may not get right to the very end regarding HIV. I've been told that some of you are doctors, some of you actually work in health protection, and so a lot of you may very well know quite a lot about HIV anyway, and so I'm not going to labour the points on that too much, unless of course you want me to. So what we'll do is we'll talk about or start right from the beginning. And what is sexual health? So obviously sexual health is more than just the absence of sexually transmitted infections. And on the screen now is a statement from the World Health Organization that it is having a full experience free of coercion and discrimination, violence, and it's a very holistic statement by the World Health Organization, which means your whole the culture and society in which you live in has to be taken into account. And that generally is the approach in sexual health. It's a holistic approach where we look at culture as well as the social context, as well as your physical, emotional and psychological well-being. To highlight that as an example, as a short case study, we had a 30-year-old female arrived in the UK 4 years ago, and she was a patient of ours a few months ago. And she just told us the story that she did have a young son in Africa by a married man who, after the son was born, he didn't want to see her anymore, and so she was living with her blood family. And then she met a lovely guy from the UK about 5 years ago, and then she came over to the UK 4 years ago. And when she was brought over, she realized it was mainly it seemed to run his business. And then she used the term, she escaped him to live with a family where where they look after her. She gets free lodging, providing she does a lot of cleaning and walks the dogs. And just to give a bit of interactability, does that raise any concerns with anyone? Feel free to put it in the chat or to shout out. I'm happy with either. Someone's put in trafficking, and yeah, and that was that it was a concern, and one of the big concern is when she was younger and she was groomed by the guy in Africa, and then she seemed, after more chatting, it seemed like the guy who she met, the supposedly nice UK guy, actually brought her over to the UK. And what he did is he beat her up, and then he sold her out to other men for sex. Her story unfortunately didn't end there, because she became pregnant, and she had a newborn baby girl, which unfortunately died soon after birth. And when the baby died, the guy dumped Jay because she could no longer claim any form of child benefits or allowances, and so he wasn't interested. And in terms of her escaping, it doesn't quite end there, because the family she's escaped to, yes, they give her food and lodgings, but she has long hours cooking, cleaning, and she's not even given permission to leave the household unless she's got prior permission. And so, yeah, so we're concerned about not just trafficking, but also effectively modern slavery as well. And yeah, so I currently work in Bath, and this is all happening in Sleepy Bath. Just noted there's quite a few comments in the chat now, so thank you all for joining in, and thank you all very much for your various comments. And so this gives a rise to, if it's just looking at absence of disease, then obviously she would have, we wouldn't have gone into this, and she was very hesitant. But now we've managed to get the police on board, we've managed to get various charities on board, and other government organisations looking into this, so, which is obviously very important. And as such, there's a lot more to sexual health than just simple management of sexually transmitted diseases, but we obviously do that. We obviously manage and diagnose HIV, provision of contraception, and obviously with that comes a large public health element of partner notification, treatment, and health promotion as well. And so where did this all start? Well, in terms of its history, well, you have to go back all the way to World War I. And during or just before World War I, you had a great swathe of the population that had some form of sexually transmitted infection. And though I haven't got it on this slide, it was reckoned that a good 30 to 50% of all sepsis deaths were actually due to disseminated gonorrhea. Now, obviously, we don't have that now, and the amount of disseminated gonorrhea in the UK is generally underreported. But back then, it was a very common thing for both syphilis and gonorrhea. And the reason why it's a big concern of the army is because all Allied forces in World War I, about 400,000 were in either hospital or unable to fight due to some form of sexual infection. And obviously, if you're missing just under 500,000 troops to fight in the what was then called the Great War, to have them shot on the local battlefield, that's not good. And so you wanted to publicize the fact that you wanted men to come in to get tested, and so you do lots of various posters. And as you may notice, there's a particular theme that follows these posters, which obviously we would do nowadays, but this was around about the First World War time. Can anyone guess who's at fault here regarding the sexual health of our armed services? Who's it blaming? Women, exactly. And obviously, this is a very unenlightened view. If you wanted to defend these photos, you could turn around and say, well, it is aimed at men during the First World War, where society and culture was different, and it's trying to educate men about the problems with sex. But you could argue, well, the way it's being done is incredibly unenlightened, because obviously it takes two to tango. And a lot of men who are in the army at this time, a lot of them are actually married, and then come back and give their partners some kind of infection as well. And so obviously a lot of blame and a lot of the culture, all the way up to quite over the decades, has all been blaming very much on women. So as someone said, extremely one-sided. And so the evolutionary timeline of sexual health is the Venereal Diseases Act in 1917, is when local authorities had to set up venereal disease centres. In the 1960s, you obviously had changes in social attitudes, and this again culminated in 1967, where homosexuality was decriminalised, and the Abortion Act of 1967 was allowed a legal abortion up to the age of 24 weeks. And in the early 1980s, that's when we had the start of the AIDS epidemic, which we may cover on more if we have a little bit of time. In terms of HIV, just to quickly skip over it, that is the modern day miracle, to be perfectly honest with you. It is probably one of the only infections I can think of which had such a devastating effect. If you was diagnosed in the mid-1980s with HIV, chances are you was probably very ill, and so your life expectancy was at best a couple of years. Compared to now, if you're diagnosed with HIV, I tell people, if you take your medicine and come to your clinic appointments, you'll probably live longer than the general population. The general population doesn't get the input and the nagging we do to improve your lifestyle, improve your diet, try and keep people to get active. And so it is a massive turnaround, and people can go on, have normal sex lives, can have children, and live a long old life and die of whatever old people die with. So it is the modern miracle. Any questions at the moment? No, so I'm just going to keep on going. So in terms of, in the context of medicine at the moment, and bringing this a little bit more up to date, there's just under 500,000 diagnoses of STIs in the UK every year. Now, obviously, I'm going to skip over the COVID bit, because in 2019 it was just under 500,000, and I dare say in 2023 it will probably be a lot closer to 500,000. Obviously, it did decrease a little bit during COVID for reasons we all know. And we have to deal with a lot of issues regarding stigma, judgment, the acceptance of some infections, and that includes common infections like herpes, which we'll talk about a little bit later, and also a lot of STIs that masquerade as other health infections. So the most common of which is, for example, syphilis. That used to be called in Victorian times the Great Pretender, and if you knew about syphilis, you knew all about medicine. And you're probably thinking, God, syphilis, that's an old disease, that hasn't been around. Well, it's backed by popular demand, and it really is. I think in the UK it's gone up around about 160, 170% over the last 15 years or so. So it is backed by popular demand, as they say. And obviously there's a big public health significance in terms of the spread of diseases. And in the southwest, including Exeter and Bristol and Bath, there's a big outbreak of gonorrhea, which you will hear about, no doubtedly, through a few public announcements through the UK HSA, and also there's been a big rise in a very big rise in syphilis as well. And obviously, when someone is ill with a sexually transmitted infection, it takes them out of the workforce, as well as the impact on and costs of treating and caring for these individuals. Okay, what I'll do is I'll let Barrett read the comments, and feel free to interrupt Barrett if there's anything you wanted me to address. Unfortunately, as my wife keeps on pointing out, I can only do one thing at a time, so I can present or I can read. I can't do both, unfortunately. There are limits to my abilities. Okay, so where does all this the stigma, this attitude, and this and the way we treat people come from? Well, it comes from our attitudes, and attitudes develop over time. They develop with culture and society. And the way we find out about our attitudes towards sex is through the NATSAL studies. That's the National Survey of Sexual Attitudes and Lifestyles. It's done every 10 years or so. We're up to NATSAL 4, which should be, if it hasn't started, it should be starting over the next few months. And you take tens of thousands of people. It varies in each cohort. Sometimes it goes up and sometimes it goes down, where you interview them and find out what the data is. And the sort of data you get is this one. So the average lifetime partners for heterosexual couples. So for men, it's now in the last study around about 12 lifetime partners, and for women it's around about 7 or 8. Obviously, if you go back in time in the 1990s, those figures are greatly reduced. That's also an example of various biases as well. So maybe back in the year 2000, when men were saying they had 12 and a half partners, that was in the height of HIV. People are very worried, and men tend to brag in surveys and say, "Oh no, I did X, Y, Z, and all these partners." Where women, they like to give, or used to like to give, social desirable answers and say, "Oh no, I haven't slept with that many individuals," and that's probably why there is a decrease in the number of partners that women report compared to the number of partners men report. But it would be very interesting to see what NatSal-4 show, to see if there is a little bit more honesty on both sides of how many partners they have. And I think it is very much changing in clinic. You'll see how people address this issue. In terms of how often you have sex, it seems like as time goes on, each generation has less and less sex. So in NatSal-3, which is around about 2010, around about, just want to see how often, I think that's 3 times per week, I believe, if I remember the stats correctly. Whereas back in NatSal-1, which is 1990, it was reported the average at being around about 5 times per week. And so I think it's a question of the young don't realise how good they've got it, or they're missing out on something there. But the numbers are decreasing, and whether it's because of there's more interesting things to do, like Netflix or Apple TV or the general internet. In Japan, for example, the amount of sex reported there is much lower than in, for example, Western Europe. Other things that the NatSal does is what age do you first have sex, and the proportion of individuals who have sex before the age of 16 is increasing. So if you ask 16 to 24s now, around about 30% will say they've had sex before the age of 16, whereas you ask your grandma and granddad when they have sex, it's around about 5 to 15%. And so it's easily doubled, if not more, as the generations have gone by. And in terms of who tends to have early sex, it tends to be the poorer educated or the most deprived tend to have sex at an earlier age. In terms of same-sex partner experience, men tend to stick around about 4 or 5%, whereas in females it tends to be going up a little bit. And so it'll be interesting to find out what NatSal-4 shows to see if there's any change in the rates of same-sex behavior. But in terms of who is more likely to have same-sex behavior, it tends to be individuals who are least deprived, in other words, more economically wealthier, and people who have, for example, gone to university. And in terms of same-sex experiences, in terms of global health, obviously there is massive health disparities between men who have sex with men compared to men who have sex with women. And so in 67 countries, homosexuality is still illegal in the world. And in a few countries, I can't remember if it's 5 or 7, it's still, in theory, punishable by death. And please note, even in the UK, in same-sex partnerships or marriages, there is very high rates of intimate partner violence and sexual exploitation, as well as substance misuse as well. And in terms of intimate partner violence and sexual exploitation, that always, obviously, that comes down to non-consensual sex or sexual assault. And sexual assault is more likely if you're young to happen between a family or friend, but as you go older, it's more likely to be an intimate partner. Okay, and that's what you see on the. I'm not sure if you can see. I'm not sure if you can see this in these 2 graphs here. Okay, I don't think that's going to change at all in NatSal-4. Which is unfortunately quite a depressing state in the UK of how many people who do get sexually assaulted on a yearly basis, unfortunately. In terms of teenage pregnancies, now this is a very old slide to show the UK is doing very poorly in terms of teenage pregnancy rates. And you're probably thinking, geez, why has this doctor, he's dropped the ball? Why hasn't he given us some new up-to-date information? Now I've left it there on purpose because there's no need to update it, because we're still one of the poorest countries in Western Europe in terms of teenage pregnancy rates. It's really a little bit depressing. However, we did have a little bit of a 40-year low, and this is how you can portray statistics favorably, if you like. So although the UK in 2014 had very low teenage pregnancy rates as far as the UK was concerned, if you look at the conception rate per 1,000 women, you can see that it seemed to be from 1993 steadily increasing all the way up to 2018, with the contraception rate per 1,000 women all falling. But however, if you use the standardized abortion rates, they also they tend to be a little bit of a drop off in 2014. So you're the public health expert, so I haven't done public health for a long time, so I'll leave you to look at the headlines and the data. But one thing's for sure, even in this clinic, the amount of individuals we refer to for termination of pregnancy, which is an abortion, and the amount of young individuals who know very little about abortion, I think is very much due to the effect of how the government has possibly cut down funds to public health for social provision of various things. And the reason why that's a very, very cagey answer is because it is such a wide spectrum of things that affect individuals' access to contraception. Okay, so it could be allowing GPs to make sure that they're trained up in order to give provision. It could be simple as health promotion within schools at a young age. And so I'm not really surprised that around about 2014-15, these rates of abortion rates start to climb quite considerably, because that's when the second round of austerity really starts to take off. But I'm not going to go too much about into politics. That becomes very boring otherwise. Right. Okay. So moving on to, so we've done about the key messages. We're going to talk very quickly about epidemiology and review of STIs in England. And so this will be just a quick review. And so obviously trends in STI, so we'll be talking about trends, risk factors, and regional rates. The best way to look at some regional rates, you probably all know this, so I'm not going to spend any time on it, is a website called Fingertips. It used to be called phe.org. Someone can write in the comments if the website name has changed to .uk HSA, but it's still the Fingertips website, which is very, very good. And here's an example it gives on various local authorities and sometimes at county level, depending on how you want to split it up. Either way, comparing 2019 to 2021, it looks as if there was a decrease in the number of STI diagnoses, but I think as the years go on, this will quickly normalize back to the 2019 rate again. We are seeing a lot more gonorrhea in 2023 than was reported in the last set of sexual health statistics in 2021, which is only 51,000. To give you an idea, the rate of gonorrhea in January last year was around about 4 in every 100,000, and now in Bath it's 13 in every 100,000, so it has actually tripled, and this was between 22 and 23, and so I would expect as the years go on, and we do actually get 2023 statistics come through, the gonorrhea and syphilis rates will be much, much higher. The good success story is the HIV rates are dropping, and that's due to obviously people taking on pre-exposure prophylaxis. But if we've got time, we can talk a little bit more about HIV. The risk factors for STI are, as you would expect, so young, single, and lots of sexual partners, not using condoms, and a history of sexually transmitted infections. The reason why a history of sexually transmitted infections is important is simply because that means sexually transmitted infections are in your sexual network, and so you're more likely to encounter the sexual infection as it were goes round the sexual network again and again and again. And if you've got one sexually transmitted infection, you're also more likely to pick up another. And so, for example, if you look at HIV acquisition, it's always higher when someone has got a sexually transmitted infection like chlamydia, gonorrhea, mycoplasma, genitalium, herpes, syphilis, for example, because a lot of sexually transmitted diseases do go around in pairs. So it's not uncommon to discover more than one STI when people come in for a checkup. And in terms of residency in inner city or ethnicity or sexual orientation, as a general rule, like everything in public health, bar breast cancer, disease follows poverty. And so the poorer you are, the more likely you are to encounter a sexually transmitted infection. Have a very, very quick look at the statistics. The rates of sexually transmitted infection are skewed, and it looks like in females between 20 and 24, it's a lot higher than it is in males. That's just because of the chlamydia diagnoses and the fact that young women are more likely to see their GP at a young age in order to get contraception. And if they come here or go to your GP to get contraception, they're usually offered a chlamydia test. And that's why that data is a little bit skewed. The older, for the men, the reason why it's there seems to be a lag is because men tend to go out with younger women. And so if you look at, for example, the male age group between 30 and 39, as a general rule, but not always, they'll be looking to go out with someone who is around about 3, 4, 5 years younger than them. And so if you look at it like that, then the bars tend to even out a little bit more. Some people don't like that explanation, but unfortunately that's how it is, I suppose. This just amplifies in terms of coexistence or coexistent infections. So if you've got one infection, you're more than likely to get another. So for example, if you have gonorrhea and you test positive for gonorrhea, you've got a 40% chance of also having chlamydia at the same time. If you're a heterosexual man, 27%, or MSM 26%. So there's generally more gonorrhea. These figures will change quite considerably over the coming months and years due to the outbreak of gonorrhea we're having at the moment. But as a general rule, gonorrhea is more commonly found in MSMs and chlamydia is not, and that's why you get a bit of a skew in the statistics there. But as you can see, if you're an MSM and you're diagnosed with gonorrhea, you're 2.3% chance of also being diagnosed with a new HIV infection. So all this is basically saying is infections do travel around quite a lot in pairs, and individuals are more at risk of certain infections depending on their sex, sexuality, and social group. And obviously, if you caught gonorrhea once, you more than likely will catch gonorrhea again. Okay, and as said, this is just a map which shows sexually transmitted infections tend to follow deprivation. So the poorer you are, the more likely you are to encounter sexually transmitted infections. And this again just shows in terms of the deprivation quintile. Okay, in terms of ethnic group, So if you are Black, British, or Asian, so if you're Black or Black British, you're more inclined to get chlamydia or gonorrhea diagnosis. Now, some people say, oh, that's because people who are Black are less likely to come to STI clinics. I disagree with that, because they come to our clinics to get diagnosed, and that's why we see the STI rates in ethnic group here. And we have various people coming to our clinic. I think the biggest marker of why people don't access sexual services is due to how economically deprived they are. And that, I think, is one of the bigger barriers, because the poorer you are, the less likely you are to come to clinic, and who are more likely to be more economically deprived. And that is where the non-white groups tend to come in. And so what we've seen with things like postal kits, for example, in most areas where postal kits have been implemented, you see a bigger uptake of individuals who can order a kit. They want to take care of their sexual health. They just can't take the day off work to get into clinic. And so they order a kit, and then they get diagnosed, and then hopefully get treated even by post sometimes. And so both postal kits have really been good at getting into the most deprived areas in society. Okay. I'm not going to skip through that. And this is just an example of HPV vaccination and the decrease in genital warts, just to basically demonstrate that Australian doctors in sexual health clinics say the only warts they see tends to be in British backpackers going through Australia. So the HPV vaccination program works very, very well. We should see a decrease in male genital warts in the UK as more and more guys get vaccinated due to the HPV vaccination program. Okay, and there's a quick summary of what we've looked into. I won't break just yet, and I'll carry on to our next bit for a whirlwind tour. And so feel free to unmute. And so I'm going to go through this very, very quickly, and feel free to stop at any time. Some of you will know this, that's why I'm not going to write too much on this particular area. Okay.
Sorry to interrupt, Bret.
Yeah.
We did have a question a little while back, I think from Victoria originally, talking about what's responsible for the big rise in gonorrhea and syphilis cases. We had some suggestions in the chat, but it would be interesting to hear your thoughts.
Okay, so I think, to be honest with you, it's very easy for me to turn around and say post-COVID lockdown frustration, but obviously with the opening up of clubs and nightclubs, and people just thinking, oh, screw it, I'm just going off to enjoy myself. That is a factor, and people have turned around to me and said, yeah, we haven't been as careful as we usually have. There is an increase access to pre-exposure prophylaxis in the community that requires PrEP to prevent HIV. And in those individuals, they are more likely to go now and have sex with either one partner, many partners. Sex clubs have restarted again, saunas have restarted again. So all these are factors that lead into it. Obviously, the dating apps have become even more popular since COVID. They were bubbling along through COVID as well, but I think they've exploded a little bit more. So if you're straight, you probably use Tinder. If you're gay, you use Grindr or Scruff. If you're a straight guy but curious, I think there's an app called Bros. There's Bumblebee. Can you name any? I've got a few people here. You can't name any. No, I've got two nurses behind me which are all embarrassed that I've asked them a question. I do apologise. Basically, there's more and more apps which, effectively, if you download the right app, you can have sex probably within half an hour with someone very, very close to you, whatever your sexual proclivity. So ease of access, and that's why it's all gone up. Another thing as well is the gonorrhea and syphilis has stayed quite comfortably within the men who have sex with men community. And so therefore, that is a group of individuals, and I'm sorry if this upsets people, the state doesn't give a shit about. And has a consequence. No one really cares that gonorrhea and syphilis rates in the MSM community have been going up for 15 years, and no one gives a shit. It's as simple as that. But because it's now spilling over into the heterosexual community, the UK HSA is putting out all the stops and is really going for hell for leather to investigate it. And I'm sure there will be, when it does hit the news headlines, questions in Parliament, and something will then be done. Maybe, and the UK HSA has even said they want to try and increase extra funding for health promotion. So you could argue the MSM community was the canary in the coal mine for many, many diseases, but is often ignored. And so when HIV came along, all what the state wanted to do was, in many countries, was to persecute the MSM community. I'll give the only good thing, one of the few good things Margaret Thatcher's government did was actually highlight the problem of HIV and to do something positive about it with education campaigns. You can argue the good bits or the bad bits about that. But when monkeypox came along, unfortunately, it was going straight back to typical 1980s attitude of, let's not publicize it, let's not do any organic health promotion, it only affects the MSM community, and so therefore let's leave it alone. There were no governmental communications about monkeypox, in my personal opinion, not that I saw, and clinics were left high and dry. I say that because I was left high and dry and dealing with it all by ourselves. Anyway, let's move on. I'm sure. Feel free to add the comments. We'll get to it all, I'm sure. And so STIs and inequalities. So if you are young, if you're from an ethnic minority group, gay, bisexual, or live in a deprived area, you are at risk or more at risk of sexually transmitted infections. That's really the take-home message, and everything can be looked through in that particular window. Okay, all this shows is the more partners you have, the more likely you are to have chlamydia. It's no real big thing. You can read the small print in the slides that I'll send to Tom after the lecture. And the rates of chlamydia are confined to the under 25s for the reasons given previously. Females are higher than men because obviously they're more often tested. There's just as much chlamydia in males. It's just men generally don't see a doctor unless something is actually wrong with their penis and genitals. If it looks all right, smells all right, and there's nothing dripping out of it, then as a general rule, men don't see a doctor. And if there's any A&E doctors, you'll probably agree with me that even men don't go to A&E, even with a heart attack, because it's not really considered that important. They have to be escorted there by their wife. But if there is something wrong with the penis, like an ulcer or there's a discharge, then they come screaming down to the sexual health unit. In terms of the clap, and so, you know, think about gonorrhea, very easy to catch, but bloody difficult to spell. And here shows the last time we had problems with gonorrhea. So this was back in 1925 up to 2015. And it shows you after 1945, there was a huge spike in gonorrhea. Well, humans like to celebrate the end of things, and that was a celebration at the end of war. And the reason why it suddenly declined was because penicillin was declassified and was allowed to be used in public use. The reason why it then increased over the 50s and 60s, it basically became resistant to penicillin and various other antibiotics, and then sexual liberation, sexual freedom. Can anyone give me a guess why it suddenly declined in 1985, 1986, 1987? Any suggestions? Stop you all falling asleep.
We were scared to have sex, Bret.
Yeah, we were all terrified of catching AIDS or HIV, the disease, the infection that causes AIDS, and so rates for all sexually transmitted infections plummeted. But from 97 onwards, there's various increases. Now, it looks as if there's a decrease between 2000 down to 2005, then a sudden increase again from 2006-07 up to 2015. That's a bit of an anomaly because the increase from 2007 upwards is we changed testing. So there we went from microscopes to PCR testing. And that's where you have this massive increase, okay? And so imagine that line in 2015. I think in 2023, you're probably looking at around about 65,000 maybe. But we have to wait for those figures to come out. So it's obviously going to be the highest it's been for a long, long while. In terms of, oh, my computer stops clicking through. Okay, in terms of gonorrhea, for example, so women, it is confined, or used to be confined to the under 25s, but in males, it seems to be more confined from the 20s and spread all the way up to 45. That's mainly the effect of men who have sex with men. They tend to have, they're not so fussy about the age and have a wider age distribution of sexual partners. And so that's why the gonorrhea spread by age is a lot broader. And obviously with gonorrhea, we're always concerned about super gonorrhea, and that it could be untreatable over the coming years. Although we've had a very nasty drug-resistant cases in various parts, that's usually been imported from places like Thailand, where antibiotics are very, very easy to get hold of, but it is becoming it's always going to be an issue there, but we do change our medications around in the UK, and so hopefully we can keep on top of it, but we'll see what this new outbreak brings. Mycoplasma genitalium is the new kid on the block, and cases of mycoplasma genitalium are increasing. It's spread exactly the same as chlamydia and gonorrhea and can cause infertility, PID, and epididymal orchitis. They're just diseases as a consequence of untreated infections, and as time goes on, we're more likely to, we only test really for people who have symptoms of mycoplasma genitalium. There's probably going to be a lot of people walking around who are asymptomatic carriers of it. In terms of genital herpes, that's a popular one. I noticed there was, when I came on, there was a talk about VZV vaccination, and that's my research and how HSV and VZV, they're all human herpes viruses, how they interact, and that's my area of research. I'm not going to go into that because I don't want to bore you, but if there are any questions, I'm happy to answer them on that front. In terms of the rates of anogenital herpes, they seem to be higher in females than in males. That's if you look at first episodes. There is a difference between the male and female immune system, because if you look at blood sample studies, you seem to have a bit more of an even spread, as it were. But people who are symptomatic of herpes tend to be more likely to be female, but there's obviously there's lots of work on that. In terms of warts, I'll just leave you with this figure, that obviously cervical cancer figures are a little bit worrying in terms of the amount of cancers that are around there, but the cervical cancer rates are going down, and hopefully the HPV vaccine program could prevent 50 to 60 cervical related HPV cancers, and another 50,000 or more other related HPV related cancers. These are head and neck cancers, anal cancers, penile cancers in both men and women, or penile cancers in men, anal cancer and head and neck cancers in men and women as well. Okay, Syphilis, yeah, as I said, backed by popular demand. I'm not going to labour it. It's just it's up, and it has a similar distribution to gonorrhea because of the higher rates in men who have sex with men, but obviously the rates in heterosexuals are increasing. And for the last for 2023, I think I've treated more people with syphilis and gonorrhea in this clinic who are straight than who identify as men who have sex with men. I'm not going to talk about syphilis, but the one thing I will say though is the number of sexual contacts you have a greater increase in the number of spread, but the less chance you have of tracing those contacts in order to treat. And so individuals that go up to clubs in London or Bristol, go to sex saunas, those individuals may have a high partner load, but you're never really going to trace all of those contacts. And that's one of the reasons why syphilis is spreading. And right at the bottom, there's more examples of sexual health apps: Romeo, Hornet, Growler, Tammy, Plenty of Fish, Badoo, Trans, Our Time, Bumble, etc., etc. I'll leave it on there so you can make a little bit of a note of that if you wanted to download a few apps for your perusal later this evening. And we're coming to the end now in terms of pubic lice. Pubic lice are not seen very often now, and that's mainly because of deforestation of their natural habitat. Obviously, people are shaving and waxing to an inch of their life, both men and women, and so we don't see this poor old organism that's being made extinct. It won't go extinct, trust me, but it looks like that. An interesting side note, so the Neanderthals had slightly different pubic hair to Homo sapiens, and so the pubic lice associated with Neanderthals died out when Neanderthals died out. Okay, so if humans ever do go extinct, we will be taking pubic lice with us. I just thought I'd put that as an interesting side note. And so obviously there's an increase, you can read it here, there's an increase in resistance to antimicrobials. There's a problem with HIV infection rates in terms of late diagnosis and getting those individuals coming to us. We need to have more sex education in schools, especially schools that are predominantly religious-based education, and obviously individuals that miss these messages who live in more deprived areas or on recreational drugs or alcohol abuse, and also gang-related sexual abuse and sexual problems as well. There's obviously lots of new innovations as well, and I won't necessarily go through all of those. And in terms of hope for the future, there's obviously HPV vaccination, herpes. We're thinking about HIV eradication, but that we're not quite there yet. For HIV, there are things like depot injections, so people don't have to take tablets. Not all clinics do depot injections because some people feel, and I'm one of them, that the depot injections are not as good as the tablets yet. But that's something there are other treatments coming out for HIV over the coming years. There's obviously point of care testing at home, which has had the University of Cardiff have done good studies on that, and there's also postal test kitting as well, and also community pharmacy testing and possibly treatment as well. So at that point, I will say if there's any questions.
Bret, thank you very much. I've been typing away whilst you were presenting, and we've been having a good interactive session whilst you gave your presentation. So thanks very much. But yes, the floor is yours. Any questions for Bret?
So I'm happy to cover monkeypox in about 5 minutes if there's no questions. But if there are any questions, feel free to either unmute and read them out or to type them up.
As you have something on monkeypox, why don't you enlighten us 5 minutes? It will be good, Bret.
Yeah, sure.
And I'll try and answer the questions via chat, and then we'll have a panel as well.
Yeah, so I won't go through every single one of these, but these will be in the slide pack. And so if we can't cast our minds back to early 2022, patients in London were being diagnosed with rashes around the mouth, genitals and anus. The vast majority were fine. It was just a weird ulcerative rash that quickly healed over. But it was noted that a few people, especially with poorly controlled HIV, were being admitted for rectal pain management. And it was eventually diagnosed as monkeypox, and then people in London realized that, oh, actually, we may have seen a few other cases of this previously. And so a lot of people felt a little bit deserted. So I apologize if there's anyone from the UK HSA. I'm not personally picking on you, but it's just, I think it's an important lesson on how lack of communication can sometimes be just as damaging as putting out the wrong communication as well. And so I think something we can all learn from on that one. And so the question is, what would you do? And what do you do? Well, what we did is we had to come up with a fairly quick plan. We had to come up with a pathway for patients. We needed to come up with how to test and what to test for and who to send it to, because at the time we just didn't know. Eventually it turned out we had to take tests in a certain particular way to rule out other infections and then send everything to Porton Down. But we also wanted to, well, what do we do with, when we do test, what do you do with the positive results? What do you do with the patients? Do they need admission to hospital? And what do the local GPs do? Do they send their patients to us? Do they deal with them at the GP clinic? Do they send them to the main hospital? As well as all that, everything has to be audible and traceable. So I had to come up with the paperwork for testing, the algorithms, consent forms, patient information leaflets. And some of this information was shared between Bath, Bristol, Salisbury, Swindon, Exeter, and various other clinics around the country, as well as London. Some things we didn't have any help on, and how do you design and come up with a virtual ward? So we had to design that fairly quickly. And obviously, although the main hospital is familiar with getting certain types of PPE equipment, so for us, we realized we had to suddenly upgrade our PPE equipment in terms and get a small set of people together who were happy to deal with monkeypox. And then you suddenly find out who in your staff are a pregnancy risk or not, because obviously monkeypox is more deadly to pregnant women and the unborn child. Okay, and then on top of that, all of that, after a few months, we then had to figure out how to give the smallpox vaccine and how to roll it out, all with zero budget. So all of this had to be done with no increase in budget. We couldn't employ anyone. We couldn't say, let's get some bank staff in to do X, Y, Z. We just had to think of it all from scratch. In terms of the epidemiology, obviously it was discovered in 58. It seems to be, it's called monkeypox because it was discovered in a research lab in a monkey, but in reality, its natural history is in things like rats and rodents. It's common in West Africa, where there is closer living proximity between someone's bed and, for example, rats that may live near, and so there's more likely to be crossover from species to species. But in the end, in the UK, we had over 3,000 monkeypox cases. In Baines, in my clinic in Baines, we had 10 confirmed cases. And none needed to be hospitalized, which was, I think, was very good. I'm not going to go too much on about the natural host. The transmission, the fact that it was centered around the mouth, anus, and genitals seemed to show that it was genital transmission. And that seemed to match up. We did have actually one case of non-sexual transmitted monkeypox, but we weren't allowed to publish it because the patient didn't give us permission, unfortunately. So that would have been one of the few cases in the UK of non-sexual transmission of monkeypox. And his presentation was a lot more disseminated. So his rash was all over his body, arms and legs, and it wasn't concentrated around the mouth, genitals or anus, which we found quite interesting. It's considered that the virus enters the body through broken skin, which is common through person-to-person sex, but obviously contact with contaminated linen is also considered a problem. It seems like the monkeypox we have in the UK seemed to be a different form from the monkeypox that was in West Africa. It certainly seems to have mutated, that's for sure. I'm not going to go too on about the clinical features, just to say the incubation period is up to 21 days. People tend to come down with a fever, headache, muscle pains, backaches, swollen lymph nodes, chills and exhaustion. But a lot of people didn't have anything. The first sign they had was actually a scab. And these are the scabs that we tended to see. And I'll bring your attention to the bottom left-hand corner, just here. I'm not sure if you can see that on these slides. And that was basically a very dark black scab with a halo around it, and they tended to fall off. And if the skin was intact, it was considered to be all over, and they could then end self-isolation. The monkeypox rashes, a lot of websites used black kids from Africa, and we never saw these type of rashes, to be honest with you, and so I never saw it so widespread on the face. It was always concentrated more around the mouth. I never saw it so florid on the hands or on the forearms. It was mainly concentrated around the genital and anal areas. And to give an example, this is what we saw. This is on a patient's testicles. On day 17, you could see a crater-like lesion with a white halo around it. On day 20, it was scabbing over. And then you can just follow the scabs until day 27, it had formally dropped off. The treatment was mainly supportive, and now we do, the monkeypox outbreak is effectively over now, and we're now vaccinating with the smallpox virus, ideally 2 vaccines at least a month apart. I will not go into HIV because I think that's enough, but if there's any particular questions about HIV, I'm more than happy to quickly dip in and dip out. It's very hard to cover the whole entire sexual health in an hour.
Bret, do you mind talking to us a little bit, just a little bit, about PrEP and PEP, please?
Yeah, okay. I can do that. So I will quickly, as I'm talking about PrEP and PEP, I'll just go to the relevant slides. And so the, skip over that one. So if you want to prevent HIV, the best way to do it is to obviously put people on treatment. That's an important one. But if you've got someone who's HIV positive and you want to prevent them from having HIV, there's a couple of things you can do. Obviously, we advise condoms, but condoms break and fall off. A much better method of preventing HIV is getting people to take pre-exposure prophylaxis, and that's what PrEP is. PrEP is 2 drugs in 1 pill called Truvada and entricytabine, and that is at the moment the tablet of choice. There are other medications you can take. There are different ways of taking it for men and women, and you can also take it event-based or continuously. And so I'm happy to talk about those individuals if you want, those particular methods of taking if you want. It might be too much detail, but either way, you take it before you have sex, and it effectively takes away your chances of contracting HIV if taken correctly. The studies which did show, some of the studies only showed around about 84–85% reduction in transmission of HIV, but when you looked at the 15% of individuals, depending on what study, who did contract HIV when they was given PrEP, those individuals didn't actually take their PrEP. And so if you did, if you go from an intention to treat down to an analysis of the data of who actually took the PrEP, then it was near enough 100%. And there has only been 3 or 4 case reports of individuals being on PrEP when they contracted HIV, and those individuals were unlucky enough to encounter a HIV that was resistant to their particular PrEP. For those individuals who are not on PrEP that have had an exposure to HIV, you then can take something called post-exposure prophylaxis, and that is where you take 3 medications, tenofovir and emtricitabine, which is the same Truvada pill which you see at the back of the screen now, together with another medication commonly called raltegravir, which is 2 pills, and you take all of those pills every day for 28 days, and that will hopefully prevent transmission of HIV, provided it started within 72 hours. Okay.
Do you mind telling us why you need to take your PEP ASAP? If you can, please, Bret.
Yeah, so post-exposure, so in terms of HIV, when it gets in the system, that's why it's sometimes better to do a whole HIV lecture on this one. So after, say you've had sex, the person you've had sex with has exposed you to HIV. Within 72 hours, HIV has got into your bloodstream and has managed to find a CD4 cell, which it has then entered into and then integrated itself into your own DNA within that white blood cell, and then is able to reproduce itself. All that happens within 72 hours. It can happen quicker than that as well. But if an individual came to me like they did today and they was outside the 72-hour window, there's nothing you can do. There's no point taking post-exposure prophylaxis. It's too late. So they have to come to the clinic or start the medication within 72 hours of being exposed. And an individual who is exposed is anyone who's had sex with someone who is at high risk of HIV. Okay, so that's men who have sex with men, trans population, people from South America, Africa, Eastern Europe, Southeast Asia, for example.